Are you ready for the top 100 secrets in emergency medicine? Then, let's go. Cause of the patient's presenting signs and symptoms. Treat ventricular fibrillation (VF) with immediate defibrillation if the arrest is witnessed. Treat with cardiopulmonary resuscitation (CPR), and then defibrillation if the arrest is unwitnessed. If the arrest is result of pulseless electrical activity (PEA), remember its common reversible causes, i.e. hypovolemia, hypoxia, cardiac tamponade, tension pneumothorax, hypothermia, massive pulmonary embolism, drug toxicity, electrolyte disturbances, acidosis, and myocardial infarction, and treat them appropriately. Pre-oxygenation with 100% fraction of inspired oxygen, FiO2, for 5 minutes or 8 vital capacity breaths, as well as passive apneic oxygenation, are critical steps to prevent oxygen desaturation during rapid sequence intubation, RSI. Never paralyze a patient unless you are certain that his or her airway can be ventilated with a bag valve mask or an extraglottic rescue device. Serum lactate is a commonly used marker to assess the extent of systemic hypoperfusion and the response to resuscitation. The primary resuscitation goals in patients suffering from shock are to maximize oxygenation, establish adequate ventilation, improve hemodynamic distribution, and treat the underlying cause. Atypical presentations of serious disease are more common in elderly patients. Aggressive symptomatic treatment, such as pain control and comfort care, is always appropriate in the hospice patient, the ED. Patients who receive multiple high-dose imaging examinations, especially computed tomography (CT), are at highest risk of long-term radiation consequences. When evaluating results of a research paper, the smaller the number needed to treat, the more effective the intervention or treatment. Of the readily available methods, rectal temperatures are the most accurate representation of core body temperature. A normal electrocardiogram, ECG, on initial presentation does not exclude acute coronary syndrome, ACS. 25% of patients ultimately diagnosed with ACS do not have a primary complaint of chest pain. Consider mesenteric ischemia when abdominal pain is out of proportion to physical findings. In a patient who has nausea and vomiting, consider causes other than gastrointestinal GI disorders. In the treatment of anaphylaxis, hypotension is the indication for intravenous IV epinephrine. Administer IV epinephrine as a drip, not as a bolus, in the non-cardiac arrest situation. When an anterior packing fails to control epistaxis, a posterior bleed originating from sphenopalatine artery should be suspected, and a posterior pack should be placed. Every ED should have an interdisciplinary, evidence-based guideline for the management of acute stroke. Pulse oximetry measures oxygenation, not ventilation. Tidal volume and respiratory rate affect the patient's ventilation and partial pressure of carbon dioxide, PaCO2. Oxygenation and ventilation problems in patients using mechanical ventilators can be managed by removing them from the ventilator and following the DOP: displacement, obstruction, pneumothorax, equipment, mnemonic. Continuous positive airway pressure, CPAP, or bilevel positive airway pressure, BiPAP, will reduce the need for endotracheal intubation in both the ED and hospital areas. A D-dimer assay is only useful to exclude thromboembolic disease in patients with a low pretest probability. Determination of pretest probability for venous thromboembolism (VTE) is critical in knowing when to initiate a diagnostic workup and how to interpret test results. Cardinal symptoms of congestive heart failure include fatigue, exertional dyspnea, paroxysmal exertional dyspnea, and orthopnea. Nitrates are first-line pharmacotherapy for the treatment of CHF, and diuretics should be reserved for those patients with fluid overload. An unstable patient with any tachydysrhythmia, regardless of the mechanism, requires electrocardioversion. When trying to decide whether the rhythm your patient is in is ventricular tachycardia, VT, or supraventricular tachycardia, SVT, with aberrancy, assume VT and treat accordingly. Calcium channel blockers should not be used to treat wide complex tachycardias. Consider ruptured abdominal aortic aneurysm in any patient with abdominal pain, pulsatile mass, and hypotension. Consider HIV/AIDS in patients at risk and who have an illness or infection, particularly those with opportunistic infections or extreme presentations of common diseases. Myocarditis should be considered in patients with significant tachycardia that cannot otherwise be explained, or in any patient with the combination of viral symptoms and evidence of cardiac disease. Epigastric pain may be caused by myocardial ischemia, so an ECG should be obtained in adult patients with epigastric discomfort, visceral type pain, or cardiac risk factors. Consider mesenteric ischemia in any patient with atrial fibrillation and abdominal pain. An external pacemaker can be used if a permanent pacemaker malfunctions. Indications for emergency dialysis include acute pulmonary edema, life-threatening hyperkalemia, and life-threatening intoxication or overdose with agents normally excreted by the kidneys. The ECG changes seen as potassium rises are a tall, peaked T wave, loss of the P wave, and widening of the QRS complex. In the emergent treatment of hyperkalemia, glucose and insulin supplemented by an inhaled beta agonist is the most effective method to drive potassium into the cell and acutely lower serum potassium. In addition, IV sodium bicarbonate and calcium chloride are indicated in patients with metabolic acidosis and a wide complex cardiac rhythm. Seizures, coma, and acute neurologic findings in a previously normal patient are the only indications to give hypertonic saline in patients with profound hyponatremia. Anion gap metabolic acidoses are common and life-threatening. The four major causes are lactic acid, ketones, renal failure, and toxic ingestions. Always measure the serum glucose in patients who are agitated, violent, diaphoretic, or comatose to rule out hypoglycemia as an easily treatable cause of these findings. It is unnecessary to gradually empty the bladder when treating an episode of acute urinary retention. Ketamine provides sedation, analgesia, and amnesia while protecting the cardiovascular status and airway reflexes, making it an ideal agent for procedural sedation in children. In patients with severe sepsis, initiate early goal-directed therapy in order to reduce the mortality rate by 25%. Simple abscesses are treated with incision and drainage and do not require antibiotics. Necrotizing infections are a surgical emergency that require emergent operative debridement, IV fluid resuscitation, and broad-spectrum IV antibiotics. Adult botulism presents as nonspecific anticholinergic symptoms followed by symmetric cranial nerve palsies and descending paralysis. Antibiotics are not recommended in children with bloody diarrhea, with concern for toxin release and development of hemolytic uremic syndrome, HUS. Traditional triage rules do not apply to lightning victims. Remember, reverse triage and concentrate on victims who appear to be in cardiopulmonary arrest. Ultrasound should be the first imaging study in children with suspected appendicitis. CT should only be used if ultrasound is equivocal and there is high clinical suspicion for appendicitis. Bilious emesis in a neonate is a surgical emergency until proven otherwise, requiring an upper GI series or surgical consultation. The highest impact intervention for a newborn or pediatric resuscitation is appropriate respiratory support. A suicide attempt should be considered in patients with illogical explanations for serious accidents. Consider testicular torsion in any male with lower abdominal pain. The antidote for acetaminophen overdose is N-acetylcysteine. It is most effective when administered within 10 hours, regardless of whether it is given orally or intravenously. Obtain a carbon monoxide CO level and treat any patient who has inhaled smoke in an enclosed space with non-rebreather, high-flow, mask oxygen. The classic triad of opioid poisoning is central nervous system, CNS, depression, respiratory depression, and meiosis. Because specific amounts of drugs ingested are often difficult to determine in small children, prolonged observation is often required to rule out a potentially toxic ingestion.